Hello, citizens of Internet. I am Dr. Ajit Virkud from Mumbai, India. I am a professor and ex-head of Department of Obstetrics and Gynecology. This is a channel that gives something extra. This podcast is inspired by the success of my textbook, which has been widely received by students and professionals alike. Each episode will delve into selected excerpts giving voice to my structured approach to topics in gynecology. Whether you're a student, a seasoned practitioner, or simply interested in the field of gynecology, I hope you will find these discussions both enlightening and engaging. Thank you for tuning in, and let's explore the world of gynecology together.
All right, so today we're going to take a deep dive into something that affects millions and millions of women all around the world.
Absolutely.
And that is menstrual pain, or as it's known clinically, dysmenorrhea.
Right. And we're drawing on the work of Professor Virkud today.
Yes, his book, Modern Gynecology, gives us a great, a pretty detailed professorial perspective on this topic.
Yeah, professorial lens.
Dysmenorrhea, it can really have a huge impact on a person's life.
Absolutely.
In terms of lost time at work, lost time studying, decreased performance.
For sure.
So we're going to really try to break this down today for all of you out there so that you can better understand this
Very common.
very, very common experience.
Yeah.
So I guess we can just jump right in. What is dysmenorrhea?
Well, so dysmenorrhea is basically, that painful cramping, kind of labor-like pain that women experience in their lower abdomen during their period.
Right.
And it's something that can be so severe that it actually prevents women from doing their normal activities.
Yeah.
And it's not always just the pain itself.
Right.
It can be accompanied by nausea, vomiting, diarrhea, headache, dizziness.
Yeah. It's amazing how many people, experience this. I mean, when you look at the numbers,
It's incredibly common.
it's incredibly common.
Yeah.
It varies throughout the world, but somewhere between 16 and almost 90%
Globally, yeah.
of women experience this.
Yeah.
And it seems like it's even more common in adolescents.
Yeah. Yeah. It's definitely more prevalent in younger women.
And then, you can break it down even further. Severe dysmenorrhea is like 3 to 10% of young women.
Right.
And then mild to moderate is 40 to 75%.
Of all women.
Of all women, yeah.
Yeah.
And then another thing that was really interesting in here is that 40% of young women who experience dysmenorrhea also experience premenstrual tension.
Right. PMT.
PMT, yeah. So it makes you wonder if those are, related or
If there's some kind of connection there. Yeah.
some kind of connection there.
For sure.
But then as women age, the numbers go down.
The prevalence goes down. Yeah.
And also after childbirth as well.
After childbirth, it goes down.
Yeah.
So it's quite interesting.
Yeah.
So I guess the material that we're looking at today breaks dysmenorrhea down into 3 different types.
Yeah. So we have primary dysmenorrhea, secondary dysmenorrhea, and then the kind of more rare membranous dysmenorrhea.
Right. So those are the 3 types that we're going to focus on today in our deep dive.
Exactly.
Okay. So let's start with primary dysmenorrhea, sometimes called spasmodic dysmenorrhea.
Right.
And I think the important thing here is that it is recurring menstrual pain, but there is no identifiable clinical cause.
Right. There's no underlying condition causing it.
No underlying condition causing it.
Yeah.
And this is actually pretty common.
It is. It affects up to 50% of postpubescent females.
Wow. 50%. Yeah. It's pretty widespread.
That's a lot of people.
It is.
So when does this type of pain typically start?
Well, primary dysmenorrhea usually starts within a few months of a girl starting her period.
All right.
And almost always within 2 years of her menarche.
Okay, so pretty soon.
Yeah, pretty soon after they start their
After they start their periods, okay. And then how long does this pain usually last?
Well, the pain usually starts right when the period starts with the onset of menses.
Yeah.
And it rarely lasts longer than 48 to 72 hours.
Oh, so it's
Yeah, it's relatively short-lived.
pretty short-lived.
Yeah, often subsiding within 24 hours.
Okay.
Yeah.
And then is it only during the menstrual flow or?
Yeah, that's a key point with primary dysmenorrhea is that the pain is only felt during the menstrual flow.
Okay.
When the bleeding is happening.
And when they're bleeding.
Yeah.
Got it. Okay. And then what does this type of pain, what does it feel like?
Well, it's usually described as kind of a cramping or labor-like pain, and it's located centrally in the lower abdomen.
Yeah.
In the suprapubic area, which is basically like right above the pubic bone.
Okay.
Yeah.
And then are there any other symptoms that go along with that?
Yeah, there can be a lot of other symptoms that are associated with primary dysmenorrhea.
Okay.
Things like malaise, fatigue, nausea, vomiting, diarrhea, lower backache, headache.
Wow.
Yeah, it can be pretty debilitating.
And those are all very common, or?
Yeah, fatigue is reported in about 85% of cases. Nausea and vomiting as high as 89%. Diarrhea, about 60%. Lower back pain, 60%. And headaches, 45%.
Wow, that's a lot.
Yeah, it's a lot to deal with.
So it's not just the pain.
No, it's not just the pain. It's like a whole constellation of symptoms.
It's a whole, experience.
Absolutely.
Yeah, okay. And then the source also mentioned something about ovulation in relation to to this.
Yeah, so primary dysmenorrhea only occurs in ovulatory cycles. So basically, if a woman isn't ovulating, she's not going to experience this type of pain.
So it's directly related.
Yeah, it seems to be directly related to ovulation.
To ovulation, okay.
Yeah.
And just to reiterate, I think the big takeaway here is that even though this is, causing all of these symptoms,
right,
there's no other clinically identifiable cause.
Yeah, there's no underlying medical condition that's causing this pain.
Yeah, it's just
the menstruation itself.
The menstruation itself.
Yeah.
Okay, great. So let's move on to the second type, which is secondary dysmenorrhea.
All right.
Also sometimes called congestive dysmenorrhea.
Yeah.
And this one is different because it's caused by...
Yeah, so secondary dysmenorrhea is pain that's caused by a clinically identifiable pelvic disease.
Okay, so there's actually like a reason for it.
Yeah, there's an underlying condition that's causing the pain.
It's an underlying condition.
Right, yeah.
Okay. And how is the onset of this type different from the first type?
Well, secondary dysmenorrhea usually begins several years after menarche.
Okay, so...
Unlike primary, which happens pretty soon after periods start. This one usually takes a few years to develop.
Okay.
Yeah. In fact, the material we have mentions an average of 2.9 years after menarche for dysmenorrhea, associated with endometriosis in adolescence.
Okay. So it can take a while.
Yeah, it can definitely take a while.
And then how about the timing of the pain? Is that different too?
Yeah, the timing of the pain is also different with secondary dysmenorrhea.
Okay.
The pain often starts before the onset of menstrual flow.
Okay, so even before?
Yeah, even before they start bleeding.
Before they start bleeding.
And it can extend for several days throughout the flow.
Oh, wow. So it's...
It can be much longer lasting than primary dysmenorrhea.
Much longer lasting than the first type.
Yeah.
Okay. And then is it always just during the menstrual flow, or is it...
No. So with secondary dysmenorrhea, the pain can be premenstrual, menstrual, and sometimes even postmenstrual.
Okay. So
yeah, it can cover the whole spectrum.
Yeah, a much larger period of time. Yeah, in fact, they even use the term triple dysmenorrhea to describe this type of pain that occurs before, during, and after the period.
And that's common.
That's a characteristic of conditions like adenomyosis and pelvic endometriosis.
Okay.
Mm-hmm.
And how about the actual characteristics of the pain itself?
Yeah, so the characteristics of the pain can vary depending on what's causing it.
Okay.
But it may be located more laterally, kind of like in the area of the ovaries and fallopian tubes.
Okay, so different from the first type.
Yeah, it might not be that central cramping pain that we see with primary dysmenorrhea.
Okay.
Mm-hmm.
And then what about other symptoms? Are there any other symptoms?
Yeah, so other symptoms will depend on the underlying cause.
Okay, so it could really be anything.
Yeah, it could be a wide range of things.
Depending on what's causing it.
Exactly.
Okay. And then the main difference here is that...
Yeah, the main difference is that with secondary dysmenorrhea, there is a clinically identifiable cause.
So there's something else going on that's causing this pain.
It's not just the...
Yeah, it's not just the menstruation itself.
Menstruation itself, yeah. Okay. Yeah. So what are some of those underlying causes?
Well, there's a whole bunch of potential causes of secondary dysmenorrhea.
Okay.
Some of them are congenital anomalies of the uterus.
Okay.
Which basically means like variations in the way that the uterus develops.
Okay.
So things like a redundant uterine horn and imperforate hymen or a transverse vaginal septum.
Right. So there could be some kind of structural...
Yeah, exactly. Some
kind of structural abnormality.
Uterus.
Yeah.
Okay. And then what else?
Then there are acquired uterine abnormalities.
Okay.
So these are things that develop later on.
Okay.
And this is a big category.
Okay.
Things like uterine fibroids, endometrial polyps, adenomyosis, which we talked about earlier with the triple dysmenorrhea.
Right.
Pelvic inflammatory disease, pelvic endometriosis, even the presence of a foreign body like an IUD.
Oh, wow.
So it really could be.
It could be a lot of different things.
A lot of different things.
Yeah. They also mentioned cervical stenosis, which is a narrowing of the opening to the uterus.
Okay.
And more rarely, pelvic congestion syndrome.
Oh, okay.
So, yeah, it's a pretty diverse range of possibilities.
A lot of different things can cause this type.
Exactly.
Okay. All right. And then finally, we have membranous dysmenorrhea.
Right.
And this one sounds kind of different, and it's also...
Yeah, it's a bit different.
Pretty rare.
Yeah, it's relatively uncommon.
So what is this one all about?
So membranous dysmenorrhea is basically when the endometrium, which is the inner lining of the uterus, is shed as a whole piece or in several large membranous pieces.
Oh, wow.
Yeah, and these pieces can actually be shaped like the uterine cavity.
So it's like the whole lining.
Yeah, the whole lining comes out intact.
Just coming out.
Yeah, it's also called a decidual cast.
A decidual cast.
Yeah.
And that's interesting because the source mentioned that term actually goes all the way back to the 18th century.
Yeah, it was first used by Giovanni Morgagni Bautista back in the 1700s.
Wow, that's a long time ago.
Yeah, it's pretty amazing how some of these medical terms have stuck around for so long.
Yeah, that's pretty cool.
Yeah.
And then the source also pointed out that this type of dysmenorrhea is sometimes seen in women who are taking combined oral contraceptive pills.
Yeah, that's right.
So there could be like a hormonal...
Yeah, there seems to be some kind of hormonal link there.
Although
the exact mechanism isn't always clear.
Okay.
But it's definitely something that's been observed.
Yeah, it's interesting.
Yeah.
And then what about the recurrence of this type? Is it?
Well, the good news is that membranous dysmenorrhea has a very low rate of recurrence.
Oh, so once you've had it.
Yeah, once you've had it, you're not very likely to get it again.
You're probably not going to get it again.
Yeah.
That's good.
Yeah, that's reassuring.
Okay. So now that we've gone over the 3 types,
right.
So let's get into like why this happens, you know, the causes, what's going on in the body.
Well, to be honest, it's not completely understood, but we've definitely learned a lot over the years. You know, way back, like in ancient Greece, they thought it was because the cervix was blocked.
Ah, interesting.
But, you know, later with better imaging and stuff, they found out that wasn't really it.
So what did they think then?
Well, in the 1930s, these researchers, Novak and Reynolds, they proposed that it was like the muscles of the uterus were contracting weirdly, you know, like either irregular contractions or just like too tense all the time. But the problem is there haven't been enough really good studies to prove that for sure.
So still a bit of a mystery.
Yeah, kind of. More recently, there have been studies done in Sweden that suggest it might be something to do with the blood flow to the uterus, like it's reduced when the pain is bad.
Ah, so not enough blood getting to the uterus.
Exactly.
Yep.
But again, more research is needed.
Okay. And what about hormones? Do those play a role?
Oh, for sure. Hormones are a big part of it. Like there's this hormone vasopressin that's higher during your period, and it seems to work with prostaglandins, which are like these chemicals in the body that cause inflammation. And then there's the idea that maybe it's nerves, like specific pain nerves are getting triggered by stuff from the uterine lining. In the past, they actually used to do surgery to cut those nerves.
Wow. That's a bit extreme.
Yeah, it was a pretty drastic measure. And, you know, of course, everyone's different. So like stress and other psychological factors can definitely make the pain worse for some people. But the hormone link is definitely there, especially with primary dysmenorrhea. Remember, it only happens when you're ovulating. And often when ovulation is stopped, like with birth control pills, the pain gets better.
Right. Now, you mentioned prostaglandins a couple of times. They seem to be pretty important in this whole thing.
Yeah, they are. The idea that prostaglandins are involved, it came up in the 60s, and now it's kind of the main theory for primary dysmenorrhea. Specifically, it's prostaglandin F2A, or PGF2A. That's the main player. It's found in the lining of the uterus, and it causes the muscles to contract and the blood vessels to constrict.
So that's where the cramps come from.
Exactly. And the thing is, the levels of these prostaglandins, they go way up right before and during your period, and that's when the pain hits.
It's all making sense now.
And you know, women who have bad primary dysmenorrhea, they actually have more of this PGF2 in their period blood. And get this, if you give someone PGF2, they can get all those other symptoms too, like nausea, diarrhea, headaches. Even their blood pressure can be affected.
Wow. So it's not just about the cramps.
Right. And the best part is if you take a medicine that blocks prostaglandins like aspirin or indomethacin, the pain often goes away.
Ah, so that's how those painkillers work.
Exactly.
What about people who don't respond to those, though? Is there something else going on there?
That's a great question. There's There's this other type of chemical, leukotrienes, and those can also make the nerves in the uterus more sensitive to pain. So some women who don't get relief from the prostaglandin blockers might be having pain because of these leukotrienes. It's like their pain system is just wired differently.
Huh. So it really is complex. It's not just one thing.
Right. And like we were saying before, psychological factors, stress and things like that, those can definitely make it worse too. It's really this whole interplay of things.
Right. Now, are there certain things that make someone more likely to have bad dysmenorrhea?
Yeah, definitely. So starting your period earlier, having longer periods, heavy bleeding, smoking, and even if it runs in your family, those can all increase your chances of having severe dysmenorrhea.
So a lot of it is just like bad luck.
Kind of, yeah. But there are things you can do to manage it.
Right. So if someone goes to the doctor, what are they going to ask and do?
Well, the first thing is they'll want to hear all about your periods. When you started, how regular they are, how long they last, how heavy the bleeding is, when the pain starts, all that. That helps them get a picture of what's going on. If the pain started years after your periods became regular, that's a clue. It might be secondary dysmenorrhea.
Makes sense.
And they'll do a physical exam too, just to check for any abnormalities, like, is the uterus the right size and shape? Is there any tenderness in certain areas? But, if it's primary dysmenorrhea, the exam is usually normal. And for teenagers who haven't started having sex yet, they might not even do that part of the exam.
Oh, okay.
With secondary dysmenorrhea, though, that's where they might find something specific, depending on what's causing it.
Got it. So what about tests? Are there any tests to, diagnose dysmenorrhea?
Well, there's no one test that says for sure, yep, you have primary dysmenorrhea. But they might do some tests to rule out other things, especially if they think it might be secondary. So that could be blood tests like a CBC to check for infection, or maybe a pregnancy test just to be sure. They might also look for inflammation markers. Mm-hmm. Sometimes they do a urine test or even a stool test. And, if they're concerned about certain things, they might do a CA-125 test, which is a marker for certain cancers, but it can also be elevated in other conditions.
So a lot of it is about ruling things out.
That's right. And if they need more information, they might do imaging, like an ultrasound, to get a better look at the uterus and ovaries. Or a hysterosalpingography, which is an X-ray that uses dye to look at the uterus and fallopian tubes.
Mm-hmm.
And sometimes they might even do a CT scan or an MRI if they really need to see what's going on in there.
Okay.
And, in some cases, if it's really unclear, they might do a laparoscopy, which is a surgery where they put a tiny camera in your abdomen to look around.
So there are options if they need to dig deeper.
Exactly.
All right. So let's move on to treatment. What can people do about dysmenorrhea?
Well, the best approach is to look at the whole picture, not just medications, but also lifestyle and psychological factors. And one thing that a lot of people find helpful, especially teenagers, is heat. Just a heating pad on the belly can make a big difference.
Yeah, that makes sense. Heat usually helps with pain.
Exactly. And there's some talk about diet, like maybe a low-fat vegetarian diet is better, and avoiding processed foods, salt, caffeine, alcohol, those kinds of things.
So eating clean.
Yeah, kind of. And some people take supplements like fish oil, B vitamins, vitamins D and E, magnesium. But honestly, there's not a ton of research to prove that those really work. One thing we do know is that smoking makes it worse, so that's definitely something to avoid.
Mm-hmm, yeah, I've heard that. What about exercise? I feel like when I have cramps, the last thing I want to do is work out.
I hear ya. But actually, gentle exercise, like even just walking or yoga, can actually help. It gets the blood flowing, which can ease the pain.
Interesting. So it's worth trying. What about things people try at home, before they go to the doctor?
Oh, yeah, lots of those. Cold showers, some people swear by those, or massaging your belly. And believe it or not, some women say that orgasm can actually relieve cramps.
Really?
Yeah. And then there's the psychological side of things. Just having a doctor who listens to you, explains things clearly, and reassures you, that can actually make a big difference in how well other treatments work. And historically, some people actually thought that getting married and having kids early could help. But, that was a different time, obviously.
Right. All right. So let's get into medications. What are the most common ones that doctors prescribe?
The big ones are prostaglandin synthetase inhibitors, PGSIs, and birth control pills. But there are others too, like mild pain relievers, things to help you relax, antispasmodics, diuretics, even other hormones besides the ones in birth control pills.
So lots of options. You mentioned PGSIs. What are those exactly?
So those are the ones that specifically block those prostaglandins we were talking about. Some of the common ones are mefenamic acid, ibuprofen, indomethacin, flufenamic acid, tolfenamic acid, naproxen sodium, ketoprofen, and piroxicam. They can be a good choice for women who don't want to get pregnant. And sometimes they're used along with NSAIDs, which are a bigger group of anti-inflammatory drugs.
Okay, so how do they work?
Well, they do a few things. They can stop ovulation, they can balance out the hormones, and most importantly, they reduce the amount of those prostaglandins in the uterus.
Gotcha.
Well, if it's primary dysmenorrhea and you don't have ulcers or any allergies to these types of medications, they can be really helpful, especially in those first couple of days when the pain is usually the worst. Ibuprofen and naproxen are common ones. They do have some side effects, but they're usually mild, like, upset stomach, heartburn, dizziness, headache, drowsiness. Less common are things like rashes, swelling, and if you take them for a long time, they can cause liver or kidney problems.
Right. It's always good to be aware of the side effects. And what about birth control pills? Do those work well for dysmenorrhea?
They do. Actually, they have a really high success rate. Like over 90% of women with primary dysmenorrhea find that birth control pills help a lot. Usually doctors will have you try them for 3 to 4 months to see how it goes.
Are there any other medications they use?
Yeah, there are some. Calcium channel blockers, like nifedipine, those can help relax the muscles in the uterus and relieve pain. They usually give you 30 to 80 milligrams a day. Side effects can include headache, low blood pressure, slow heart rate, constipation, things like that.
Okay, so some things to keep in mind. What if none of that works, though? Is surgery ever an option?
Surgery is definitely a last resort, and usually only for secondary dysmenorrhea or, really severe primary dysmenorrhea that just doesn't respond to anything else. One procedure they used to do was dilating the cervix, stretching it open under anesthesia. The idea was that it would disrupt the nerves, but it only worked about 25% of the time, and even then the relief was temporary.
So not ideal.
Right. Then there are more invasive procedures like presacral neurectomy and uterosacral nerve ablation. Those can actually be effective for up to a year, but they're really only for women who have chronic pelvic pain and haven't gotten better with anything else, or for certain types of cancer, or specific cases of endometriosis where the nerves are involved. Presacral neurectomy can actually cure the pain in about 80% of women. So yeah, it's a big decision. And sometimes they inject alcohol or anesthetic into the ligaments around the uterus to kind of numb the nerves. That can help, but it's also temporary.
Sounds like a lot to consider.
Yeah, it is.
It's clear from the research that, for a lot of women, this is really a serious condition. And it's important to take it seriously. Our source materials really stressed empathy.
Absolutely. I think a lot of times women just want to feel heard and understood. It's not about needing sympathy, but just having someone acknowledge that their pain is real and valid. That's a huge part of feeling better.
Yeah, I totally agree. Now, what about some of the less traditional treatments? I've heard of things like acupuncture and supplements.
Right. So there are a lot of things people try, and some people find relief with acupuncture or acupressure. There's also herbal medicine, nitroglycerin patches, medications that affect the beta-adrenergic system and leukotrienes, even hypnosis. But the research on them is pretty mixed. One thing that can be helpful is TTNS, transcutaneous electrical nerve stimulation. It's like these little pads that deliver electrical impulses, and you can control the intensity. It can be good for pain relief. But for things like acupuncture and acupressure, the evidence is a bit weak.
Okay, so some of those are worth looking into, but it's good to keep expectations realistic. And finally, our source material talked about yoga. I know yoga is good for a lot of things, but how does it help with dysmenorrhea?
Well, in India, yoga has been used for centuries to relieve menstrual cramps. And there are specific poses, asanas, that are thought to be particularly helpful, like child's pose, bound angle pose, reclining bound angle pose, head to knee pose. All of those can help stretch and relax the muscles in the pelvic area and improve blood flow.
Sounds relaxing. What about when it's secondary dysmenorrhea? Is the treatment different?
Yeah, with secondary dysmenorrhea, the main thing is to treat the underlying problem. So if it's an IUD causing pain, they might take it out or suggest NSAIDs. But often, surgery is the best option. They might give you NSAIDs in the meantime to manage the pain until you can have surgery. And for endometriosis, they use specific hormones like danazol, GnRH agonists, progestins, or even birth control pills. And calcium channel blockers can also help with those muscle contractions.
Gotcha. Well, this has been really informative. Lots to think about. To wrap things up, what are the key takeaways?
So, I think the biggest thing is to remember that dysmenorrhea is a complex issue, and it can really affect women's lives. It's not just bad cramps, and there are different types, primary and secondary, depending on whether there's an underlying medical condition. Prostaglandins are a big part of the picture, especially in primary dysmenorrhea. And when it comes to treatment, there are lots of options, from lifestyle changes to medications to surgery.
Yeah, and it's important to remember that every woman is different, so what works for one person might not work for another. And it's crucial to find a doctor who listens and takes your pain seriously. And actually, one of the things that really stuck with me from the research was this quote from a young woman. She said, "Boys, dysmenorrhea is like kicking your balls every few minutes for 5 days straight. We don't want your sympathy, but your understanding would be great."
Yeah, that's a powerful image.
It is, right? It really drives home how intense this can be. So to our listeners, we hope this is giving you a better understanding of dysmenorrhea. If you're struggling with it, don't suffer in silence. Talk to your doctor and do some research. There are resources out there to help you.
Definitely. It's important to advocate for yourself and find what works best for you.
Thanks for joining us for this deep dive. We'll see you next time.